Very good evening to all of you. I welcome you all for the second session of Neuroimmunology SIG. Like last week, today we have a guest lecture followed by 5 short case presentations. I'd like to request our President, Dr. Shabalabhati ma'am, to introduce the speaker for today, the moderator and expert for today's session. Over to you, ma'am.
Thank you, Mahesh. Thank you all. Good evening, good morning, and good afternoon. Thank you all for joining. Asmita, can I have the slides, please? So today we are going to be having a discussion on autoimmune encephalitis by none other than Professor Margherita Nossarini, who's Assistant Professor of Pediatric Neurology at University Hospital of Padua in Italy. And her research interest is pediatric neuroimmunology with a focus on autoimmune encephalitis, acquired demyelinating syndromes, and treatment. And she's honorary fellow in pediatric neurology research in Sydney, Australia, under the guidance of Professor Russell Dale. So we have a very really experienced expert who's who's focused in autoimmune encephalitis and has been working under Russell Dale. And our experts for the day are Dr. Tipu Sultan, who is head of the Department Pediatric Neurology, Children's Hospital, Lahore, Pakistan. And his research areas have been epilepsy, neurophysiology, neurogenetics, neuromuscular, and also autoimmune disorders. And then we have next expert was Professor Brajesh Udani. He's consultant child neurology and epilepsy, comprehensive epilepsy center, and heading in PD Handuja National Hospital and BG Wadia Hospital for Children, and also SRCC Children's Hospital, Mumbai. And he's a very astute clinician and an amazing human being. And then Professor Hassan, our dear friend from Turkey, who is heading the Pediatric Neurology Association in Turkey. He's a pediatric neurologist, epileptologist, head of the Department of Pediatric Neurology, Ege Children's Hospital, Izmir, Turkey. And he has a lot of publications and has been awarded by the Turkish Scientific Research Council and research fellowship at Harvard University. Thank you so much, Dr. Hassan, for joining. And our moderator is Dr. Bishwarup Chakravarti, who was our alumnus and who passed out this DM Pediatric Neurology, which I was mentioning initially to our speaker that we have completed 20 years of a DM Pediatric Neurology program this year. And he passed out and completed it in 2012. And he's currently working as additional professor as my dear colleague of mine. And his interest is pediatric sleep, neuroimmunology, neurocystic cirrhosis, and status epilepticus. Dr. Bishwarup, I would request you to moderate, and all the Q&As you can take, and very importantly would be the timekeeping in the in the cases. And we are really overwhelmed by the interest by so many people from India and Turkey for presenting cases. Just request that to allow everybody to present, we should stick to time, for 6-minute presentation, 2-minute discussion by the junior presenter, followed by the comments by the senior presenter. Yeah. Over to you, Dr. Bishwarup.
Yeah, thank you, ma'am. So without any further delay, so over to Dr. Professor Margherita Nossarini, ma'am. Please start your talk. Yeah.
Good evening, everyone. Thank you for the invitation. I'm excited to be sharing this session with you, and congratulations to the organizers. So we'll be talking about pediatric autoimmune diseases of the central nervous system with focus on autoimmune encephalitis. So this is what we are going to talk about, autoimmune CNS disorders mediated by antibodies, and in particular mediated by antibodies targeting cell surface antigens of neuronal and glial origins. We're going to start with autoimmune encephalitis with antibodies targeting the neuron. So what is autoimmune encephalitis? What is encephalitis? Let's start with this. As you know, encephalitis is an inflammatory condition of the brain parenchyma with associated neurologic dysfunction. The etiologies can be different, mostly including infectious etiologies, autoimmune immune-mediated causes, but up to 30 to 40% of cases remain with unknown etiology. So when we talk about autoimmune immune-mediated encephalitis, there are several different conditions that can go under this denomination, but we mostly mean by autoimmune encephalitis, we usually mean encephalitis mediated by antibodies targeting the neuron. And this class can be further subdivided into conditions, autoimmune encephalitis, mediated by antibodies targeting the surface of the neuron or intracellular antigens. So here you can see the conditions mediated by antibodies targeting intracellular neuronal antigens. The antigens are depicted in yellow. As you can see, they're inside the neuron, and they cannot directly be accessed and targeted by the antibodies, which are depicted in blue. So in this case, in these conditions, the antibodies are not considered directly pathogenic because they don't directly bind the antigen, and the disease is thought to be predominantly T-cell mediated. These conditions are relatively rare in children, and they are relatively frequent associated with tumor. So these are not the conditions that we're talking about mostly. We're mostly going to talk about, instead of encephalitis, with antibodies targeting neuronal surface antigens instead. You can see that the antigens are on the cell surface in this case, and they're directly bound by the antibodies. So the antibodies directly bind them and cause directly their effect. So in this case, the antibodies are considered pathogenic. These conditions are relatively more frequent in children, and they're less frequently associated with tumor, and they show generally a good response to immunotherapy. These are all the different types of antibodies targeting neuronal surface antigens. As you can see, it's quite a few of them described relatively recently, but the ones with colored backgrounds are the ones that are more frequent in children. And in particular, anti-NMDA receptor encephalitis is by far the most frequent one in children, and the one that we will use as a model for other autoimmune encephalitis. So what are the diagnostic criteria of encephalitis and autoimmune encephalitis? These are the 2013 diagnostic criteria for encephalitis of presumed infectious or autoimmune etiology. The major criteria that's necessary for making diagnosis that of altered mental status lasting about 24 lasting at least 24 hours. By altered mental status, we mean a decreased or altered level of consciousness, lethargy, or personality change. So there's quite a broad array of possible alterations. To meet the diagnosis of definite, probable, confirmed encephalitis, then 3 additional criteria are necessary, minor criteria, or 2 additional minor criteria for possible encephalitis. And these minor criteria include fever, new onset generalized or partial seizures, new onset focal neurological findings, CSF gliocytosis, abnormal brain parenchyma on neuroimaging suggestive for encephalitis, and abnormal EEG in keeping with encephalitis. But as I said earlier, these criteria do not differentiate between autoimmune and infectious encephalitis. So in 2016, the first criteria for autoimmune encephalitis were proposed, where diagnosis requires subacute onset in less than 3 months of working memory deficits, altered mental status or psychiatric symptoms, and at least one of new focal CNS findings, seizures, CSF gliocytosis, MRI features suggestive of encephalitis after reasonable exclusion of alternative causes. But these criteria were drafted for adults, and we know that things are often different in children. So in 2020, the first criteria for autoimmune encephalitis in children were proposed, which require evidence of acute onset on subacute, acute onset of neurological and psychiatric symptoms over 3 months, within 3 months, and clinical features, including altered mental status or altered level of consciousness, or EEG with slowing of or epileptiform activity, focal neurological deficits, cognitive difficulties, regression, movement disorder, psychiatric symptoms, seizures, with paraclinical evidence of neuroinflammation, including CSF pleocytosis and or oligoclonal banding, MRI features, and where this was done, brain biopsy showing inflammatory infiltrates. Of course, autoimmune serology should be done, which may show the antibodies. According to the presence of these features, patients can meet the diagnosis of a possible, probable antibody negative or definite antibody positive autoimmune encephalitis. So let's have a little look at specific types of autoimmune encephalitis in children, starting with NMDA receptor encephalitis, which, as I said, is by far the most frequent one. The NMDA receptors are ion channels gated by the excitatory neurotransmitter glutamate, are widespread in the CNS and essential mediators of synaptic transmission and plasticity. NMDA receptor encephalitis was first described in 2007 in women with the variant teratoma, but it soon became increasingly evident that the disease can occur also in men, also without tumor, and also in children. And in particular, now we know that nearly half of the cases have onset in childhood age. The condition affects women predominantly amongst young adults, but the gender balance is more equal in children, with only a slight predominance of females. In most of the cases in childhood, there's no known trigger. In a subset of cases, there is the diseases caused by ovarian teratoma or other tumor. As you can see in the diagram, the proportion of patients with tumor is very, very low in patients 0 to 10 years, whereas it's a bit higher in adolescents and even higher among young adults. Then a small subset of cases, again, is triggered by a preceding viral encephalitis, especially herpes simplex virus encephalitis. And probably there are a set of other triggers that we don't know yet. The antibodies are produced in the periphery, probably thanks to the expression of the epitope ectopically in the periphery, for example, by the tumoral tissue. The epitope is presented to the immunologic system in the regional lymph nodes. Their naive B cells exposed to the epitope become antigen-experienced memory B cells and differentiate into antibody-producing plasma cells. Then these cells cross the blood-brain barrier and make it into the CNS, where they undergo affinity maturation, clonal expansion, and differentiation into antibody-producing plasma cells. Therefore, they keep producing the antibodies intrathecally. How do the antibodies exert their action? This changes in different antibody specificities. As regards the NMDA, as you can see here, the antibodies bind their target directly, as we have already seen, and cause cross-linking and internalization of the NMDA receptors. You can see it also here. The antibodies bind multiple NMDA receptors, cause cross-linking and internalization. Therefore, the density of the receptors is decreased on the surface. So what's the disease like clinically? There's often a viral prodrome and a non-specific illness preceding the onset of the encephalitis. Then there is a phase that may last a few weeks with psychiatric symptoms that can be subtle, maybe even just a mild change of behavior. There can be language dysfunction, sleep disorder, memory deficits, and there can be seizures that definitely bring the patient to the medical attention. Whereas the previous symptoms are often a bit subtle, and that's also why the patients are not brought into GEG straight away. But when there's a seizure, of course, these patients are brought to medical attention. Then there is a phase lasting weeks to months of profoundly decreased consciousness, where patients are often in the ICU, they have movement disorder, autonomic instability, seizures, potentially again. And this is the most challenging phase, of course. We also know that the clinical features change depending on the age of onset, in particular in children, in younger children. As you can see from the diagram, in the red and orange part, there's more seizures and more movement disorders compared to adults and to adolescents. The MRI is normal in most patients or showing non-specific changes, T2 flare hyperintensities, whereas the EEG is abnormal in most patients, generally in a non-specific way, showing focal or diffuse slowing, while in a minority of patients, especially adults, a pattern denominated extreme delta brush that you can see here has been described. So the acute phase is followed by a very slow recovery, lasting months to years, where there can be prolonged deficits, especially in the neuropsychological and psychiatry areas. Outcome is generally relatively good, but death may occur in the acute phase, and there can be subtle neuropsychological sequelae and also some psychiatric symptoms staying. And relapses are described in a minority of patients, but they can occur even at distance from the onset. I'm going to mention other types of autoimmune encephalitis, much rarer in children. So autoimmunity with LGI1 and caspr2 antibodies may cause different clinical syndromes, including also encephalitis. There can be a non-specific type of autoimmune encephalitis or limbic encephalitis, which is a clinical syndrome with memory and psychiatric disturbance, sleep disturbance, confusion, seizures, and hyponatremia. It may be associated with thymoma in a minority of adults and even less frequently in children. GABA A receptor encephalitis is a very rare type of autoimmune encephalitis, but it's also been described in children, affecting females equally compared to males, and it may be associated with thymoma in a minority of cases, and even less frequently so in children again. It is characterized clinically by very difficult to control seizures. So drug-resistant seizures, status epilepticus, epilepsia partialis continua. This is its most specific feature. There can be also memory problems, cognitive impairment, and movement disorder, which may therefore, which bring it as a differential diagnosis with NMDA receptor encephalitis. And but the distinctive features is its MRI from the radiological point of view. In fact, here the MRI is abnormal in most cases, so very different to NMDA receptor encephalitis, and it has multifocal, asynchronous, cortical, subcortical, T2 flare abnormalities, as you can see here. So multiple abnormalities in different regions and occurring at different times. Finally, yet another even rarer type of encephalitis, anti-D2R antibody encephalitis, which has been described really infrequently and mostly in children, characterized mostly by movement disorders, psychiatric in cognitive symptoms, with MRI showing abnormalities at the basal ganglia, symmetrical basal ganglia hyperintensities in T2. So management and diagnosis of autoimmune encephalitis can be challenging. The most important differential diagnoses include other CNS autoimmune conditions, including CNS vasculitis, systemic inflammatory conditions, infectious conditions, metabolic, neoplastic, psychiatric disorders. So we should carry out a broad workup to exclude a differential diagnosis. So let's talk about treatment. Why do we treat it? Why do we treat autoimmune encephalitis? As we said earlier, in encephalitis associated with cell surface antigens, the antibodies are considered pathogenic. They directly exert the pathologic effect. So this poses the main rationale. And the antibodies have been shown to cause reduction of NMDA receptor clusters on the surface of neurons. And this reduction is titer-dependent, selective, and reversible. They have also been shown to be directly epileptogenic and to directly cause memory and behavior. So this poses the foundation for the rationale of treating an NMDA receptor encephalitis. But also we have clinical evidence on the immunotherapy for an NMDA receptor encephalitis. In fact, we've got literature data showing that there's beneficial effect of immunotherapy versus no immunotherapy, both on outcome and on relapses. With data showing that beneficial effect of immunotherapy when it's used early versus late immunotherapy. And the beneficial effect of second-line immunotherapy, so a more aggressive immunotherapy compared to less aggressive immunotherapy, especially in severe cases. So how do we treat it? I'm mostly going to refer to these recent international consensus recommendations for the treatment of pediatric NMDA receptor encephalitis. So treatment is generally organized into a first line, second line, and maintenance immunotherapy. Let's have a closer look. First line immunotherapy is generally with corticosteroids. Intravenous methylprednisolone is generally the first immunotherapy used, and it should be used in all patients unless they're already back to baseline at the time of diagnosis. It's usually given in pulses, and it can be followed by oral prednisone taper. Or pulses can be repeated monthly, for example, for a prolonged immune modulation. Corticosteroids have widespread effects on all stages of inflammation and also have widespread side effects, which are very well known, though, but for short-term use, they're generally manageable. Intravenous immunoglobulin should be considered, especially in severe cases or in case of an inadequate response to corticosteroids after about 1 week after initiation of corticosteroids. IVIG is pooled IgG obtained from the plasma of several thousand of donors. It's been used for decades as a replacement therapy in immune deficiencies and more recently as an immunomodulatory agent in autoimmune disorders. It has widespread mechanisms of action, not all completely understood, but in this case, it also probably, the main effect is that of cytokine or autoantibody neutralization. It's generally administered in infusions over 2 to 5 days, 2 grams per kilogram, and that can be repeated every about 3 to 4 weeks. There's a higher risk of adverse reactions with higher doses, higher rate of infusion and at first infusion. And adverse reactions are relatively frequent, but mostly mild, transient, and reversible. Therapeutic plasma exchange then should also be considered, especially in severe cases or in cases of inadequate response to other first-line immunotherapy. Therapeutic apheresis procedures are described in these guidelines on the use of therapeutic apheresis in clinical practice, where, as you can see, therapeutic plasma exchange is just one of the possible therapeutic apheresis procedures. This is a procedure where the blood of the patient is passed through a medical device, which separates out plasma from other components of blood. Then plasma is removed and substituted by a replacement solution or a combination of crystalloid colloid solution. This results in the removal from plasma, from the circulation of pathogenic autoantibodies, such as in the case of autoimmune encephalitis with antibodies. This is carried out usually in 3 to 7 separate exchange procedures. And it's interesting to notice that NMDA receptor encephalitis has been included in the conditions, in the indications for therapeutic apheresis since 2016. There can be different adverse reactions, including complication of central venous access, citrate-induced hypoglycemia, inadvertent removal of a medication. Indeed, plasma exchange may reduce the level of, for example, of IVIG, of rituximab, of other monoclonal antibodies. There can be complications related to non-plasma replacement solutions, such as depletion of non-pathogenic blood components, or adverse reactions correlated with donor plasma, for example, anaphylactic reactions. Therapeutic apheresis plasma exchange may pose particular challenges in severe, dysautonomic, small, non-cooperative patients. Therefore, it is often carried out in the ICU with close monitoring before, during, and after the procedure, and its actual feasibility depends on the expertise of the apheresis team very often. So if a child has already received 2 first-line immunotherapy, but the improvement is still inadequate, then escalation to second-line immunotherapy should be quickly considered. And here, rituximab is generally the drug of choice. Rituximab is an anti-CD20 chimeric monoclonal antibody which target the CD20, which is expressed on a set of pre-B cells to memory B cell, early plasmablast B cells. And it's not expressed on antibody-producing plasma cells. Therefore, as you can see here again, rituximab targets indirectly the antibody-secreting cells by targeting the depletion of the pool of pre-B cells and mature B cells, indirectly resulting then in the reduction of antibody-secreting cells. It's usually given in weekly infusions for 4 weeks, but there are other treatment regimens that can be used. And safety issues usually include infusion reactions, risk of hypoglobulinemia, and of infection. In case of poor inadequate response of rituximab, 1 to 3 months after initiation of second line, then cyclophosphamide may be considered. This is an agent causing irreversible impairment of DNA replication and transcription, resulting in cell apoptosis. It's usually given in 6 monthly infusions, and the safety profile is a little bit less favorable than that of rituximab, including risk of bone marrow suppression, infection, gonadal and bladder toxicity, and others. What if a patient still doesn't respond adequately 1 to 3 months after initiations of 2 second-line immunotherapy? Then an escalation to another agent, such as tocilizumab, may be considered. Tocilizumab is an humanized anti-interleukin-6 receptor monoclonal antibody used in rheumatology, which has been more recently used also in neuroimmunology. Interleukin-6 is a cytokine with widespread effects predominantly pro-inflammatory effects. And by targeting the interleukin-6 receptor, tocilizumab results in blockade of B-cell proliferation and differentiation into antibody-producing cells, amongst other effects. Its evidence of use in autoimmune encephalitis is still limited, where this is one of the main papers showing its evidence in an NMDA receptor encephalitis. Maintenance immunotherapy, long treatment immunotherapy is generally not required in an NMDA receptor encephalitis, but it may be considered in refractory patients. This is usually carried out with rituximab redosing, so where another cycle of rituximab can be administered after 6 months from the initial cycle, or when CD19 B cells repopulate. Or mycophenolate mofetil is another agent that can be used for maintenance immunotherapy. It's an oral agent with potent cytostatic effect on lymphocytes B and T with a reasonable safety profile. I'm going to mention 2 specific situations, and NMDA relapse. As we said, this occurs in a minority of patients, but it can occur. And in this case, there should be a lower threshold for use of second-line immunotherapy and for maintenance immunotherapy. And NMDA receptor encephalitis triggered by herpes simplex virus encephalitis. In this case, the patients should be treated with immunotherapy in a similar way to those with naive NMDA receptor encephalitis. So we've talked about immunotherapy, but I'm just going to briefly mention symptomatic treatments, as we know that these are very important in this condition, especially as regards psychiatric symptoms. And these should certainly be managed with the help of child psychiatrists. Agitation is another issue, and movement disorders as well, which can be quite invalidating in the acute phase. And finally, tumor removal should be carried out, of course, where appropriate. Oncologic searches should be thorough initially in all patients, should be targeted to the specific type of patients, the age, the gender, and the type of autoimmune encephalitis. And they should also be carried out again, also depending on the patient characteristic and the type of encephalitis, and also on the patient response to treatment. In particular, in case of poor response to immunotherapy or in case of relapse, oncologic searches should be carried out again. So there's what's new in the treatment of autoimmune encephalitis. There's a lot of research in this field, and there are a plethora of new treatments that are being considered in the literature, that are being evaluated, although still with very, very little evidence, especially to target that subset of patients with poor response, although they are a minority. So new targets are being considered, and I guess we'll hear about this in the next year. But we talked about antibodies against neuronal antigens, cell surface antigens so far. Let's have a look at antibody-associated demyelination and antibodies targeting glial cell surface antigen. And in particular, I'm just going to mention MOG-associated disorders. As I said, we talked about neurons so far. Now we're moving on to other elements. In fact, autoimmune encephalitis no longer, with increasing research in this field, we know that it's not only associated to antibodies targeting the neuron, but there's also encephalitis associated to antibodies targeting the astrocytes, for example, and oligodendrocytes, anti-MOG cortical encephalitis. What is myelin oligodendrocyte glycoprotein, MOG? This is a protein located on the surface of CNS myelin and oligodendrocytes, whose function is not completely understood yet. The disorders associated with MOG antibody can have different phenotypic expression, as we know. The most frequent one being ADEM. So most patients with MOG-associated disorders have an ADEM phenotype. The second most frequent phenotype in children is optic neuritis, followed by transverse myelitis and other rarer phenotypes. This is similar to adults, but this is specific to children in this case. I'm going to mention these specific other phenotypes, these emerging phenotypes. In fact, among these emerging phenotypes, an autoimmune cortical encephalitis phenotype has also been described increasingly, which is different to the other phenotypes because it has no demyelinating lesions or of the white matter. So it may have cortical lesions or no abnormalities, at least at onset. Later on, it can stay like this, or it can develop white matter lesions. So it's an autoimmune phenotype associated with MOG antibodies. What's treatment like in this case? I'm going to refer to the 2020 European Pediatric MOG Consortium consensus on treatment, where IVMP, again, is the first treatment for these patients, which in case of no improvement after 3 days or insufficient improvement after 5 days can be followed or associated with IVIG and plasma exchange. Oral steroid taper can also be done with oral prednisone, and it's increasingly used for about 3 months. Maintenance treatment is generally not necessary, again, at first episode of MOGAD, but it is definitely suggested, recommended in case of relapse. So how's it done? So after acute treatment for a relapse, then the possibilities for maintenance treatment include MMF or azathioprine or rituximab or IVIG. And then there's an escalation protocol in case of relapse, for example, with MMF or azathioprine. It is recommended to switch to rituximab or IVIG. In case of further relapse, it's recommended to combine rituximab and IVIG. And in case of further relapse, to combine rituximab and IVIG and maintenance oral prednisone. So why should a patient still relapse? Of course, there can be patient-related or disease-specific related issues that we don't completely understand yet, but common reasons for relapse could be too low a dose of oral prednisone, in case of IVIG treatment, too long intervals between maintenance administration or too low a dose. In case of ASA or MMF, we know that the first few months of treatment are still a window of vulnerability when the patient is still not completely covered by this immunotherapy. So another immunotherapy such as oral prednisone should be associated. And in case of rituximab, we know that in a small subset of patients, there's failure to produce B-cell depletion. So rituximab doesn't work for reasons we don't understand. Or there can be an earlier occurrence of B-cell repopulation. So indications for maintenance immunotreatment and maintenance treatment, long-term immune suppression include clinical relapse, as we said, but also poor recovery from the first initial event, whereas exceptions include late relapses with good recovery. In this case, the treatment can be sort of personalized. And finally, the consensus also allows for the escalation of maintenance treatment until cessation after 2 years of disease stability. So finally, as we have seen, this is an expanding group of conditions involving not only the neuron, but other cells of the glia as well. They're overall rare, but NMDA receptor encephalitis and MOG-associated disorders are not so rare in children. So, and we have an evolving class of treatments for an evolving class of disorders. Challenges include that of incompletely understood pathogenesis, need for biomarkers correlating with disease course and treatment response. And key concepts are those of precision, diagnosis, and treatment, along with a timely diagnosis and treatment. Therefore, it's important to keep these disorders in mind, diagnose fast and treat fast. Thank you for your attention.
Thank you, Professor Masadini. That was really interesting, and I think it was every one of us must have learned a lot in the last 40-45 minutes. It was really a very interesting talk. So now moving on to the experts. So we start with Rajesh Udani, sir. Sir, your opinion and your comments.
No, I think thank you, Professor Nausadin. It was really a very comprehensive, complete review of the recent updates, etc., in autoimmune encephalitis. You know, I have a couple of problems which I wanted to ask you about. One is this concept of seronegative encephalitis. So when you have a seronegative acute encephalitis, what is your opinion on the use of PET scanning? Is it something which you regularly use? Is it very often helpful in differentiating other causes of encephalitis from autoimmune? And the second question is about, yeah. Oh, sorry, I give the second question later.
Yeah.
Can you just talk about PET scan?
Thank you for the question. In fact, the issue of seronegative autoimmune encephalitis is a very relevant one in clinical practice. We saw that the current criteria also allow for the diagnosis of seronegative autoimmune encephalitis. So when clinical and investigational features are present, then we can actually formulate a diagnosis, which also allows access to treatment, which can be carried out in a similar way to seropositive autoimmune encephalitis. Of course, treatment and management is a bit more tentative here, and we are less able to give a precise counseling to families because we don't know all the data in our hands. We don't have a name and a surname to the disease. PET scan is not required in the formal criteria, but sometimes it can provide some useful information, for example, showing different metabolism in some areas, which substantiate the clinical suspicion, especially if the MRI is not conclusive, which is often the case. So the data are not definite there, but I think the use is definitely increasing in this field. And I think we need more data to provide sort of standardized data criteria for that to help in clinical practice.
Yeah. Thank you very much. Because the problem is seronegative encephalitis is that you may be including a lot of not immune, so non-immune encephalitis as well, especially in countries like India, where there's a lot of other developing nations. There's a lot of different viruses, etc., which you may not be able to convincingly exclude. The second question is on this. I've always had a problem with this MOG severe ADEM and MOG cortical encephalitis, because there is a kind of a blurred zone between the two. They sort of overlap. You may have basic ganglia changes. You may have sometimes cortical and subcortical wide matter changes in severe ADEM, especially, and they have very similar clinical symptoms as cortical encephalitis. So is there? I mean, because the prognosis is much better, in the encephalitic group it's supposed to be much worse. How difficult do you find it to sometimes differentiate the two?
So I would say that we should stick to the diagnostic criteria for ADEM to help us differentiate between these two. And in particular, ADEM is characterized by involvement of white matter predominantly. There can be basal ganglia involvement, gray matter, especially deep gray matter involvement. But in the autoimmune encephalitis associated with MOG is characterized by the lack of this white matter involvement, at least in the beginning, initially. There can be gray matter involvement or even negative MRI. So that MRI picture, only with cortical, maybe limited cortical involvement or basically negative MRI, stands very much against an ADEM phenotype. So that's what differentiates it the most. Then in a subsequent phase, even patients with MOG-associated cortical encephalitis can go on to develop white matter demyelination, like in the most frequent MOG-associated phenotype. But at the beginning, they can really look like a MRI negative or just cortical associated encephalitis. And as regards severe MOGAD ADEM, we know that there is also another emerging and very rare phenotype described in these patients, that is the one of leukodystrophy-like pattern. So patients who are very, very young, it's been described in a few patients and very young, who have an ADEM-like pattern, but very, very extensive, sometimes tumefactive pattern, and they are characterized by a poor outcome.
Yeah. Thank you very much. Thank you for those comments.
Yeah, Professor Tipu Sultan, sir, please, your comments.
Thank you, Professor Nosardini. It was an excellent talk on perhaps one of my favorite topics these days is autoimmune encephalitis. Just wondering, as in the initial conversation, the host Shifali said about the experts from not only resource rich, but also from the resource poor or resource challenging countries. In our experience, as initially said by Udani, about the seronegative autoimmune encephalitis. So what I experienced over the years, wherever we smell autoimmune encephalitis, wherever we suspect autoimmune encephalitis, generally we used to treat with solomedrol, irrespective of the availability of the report, because that may take few days. Initially, it was a bit longer, but in the past 5-6 years, because of its widespread availability, now turnover times comes to 2 to 3 days. But wondering how quickly you jump from one tier to another tier. For instance, if we complete solomedrol in a span of 5 days with relatively little improvement, clinical little improvement, irrespective of the antibody titer, how quickly you jump to another tier, whether it's plaques, whether it's rituximab or cyclophosphamide or whatever the level of drug or treatment is. But the difference between the tier 1 and tier 2, what's your experience? Sadani.
As you said, the antibody titer is not very relevant for treatment in this condition. So I think only clinical severity should guide treatment. The recent treatment recommendations try and give some practical parameters and timing for escalation. So when to escalate. Generally speaking, if only corticosteroids are started, but there's no adequate response after 5 days of solomedrol, then escalation to another first-line immunotherapy should be chosen. For example, with IVIG or plasma exchange. then this can be a little bit modulated according to the severity. If the patient is very, very severe, escalation can be a little bit quicker. Whereas if improvements are being observed, subsequent stages can be slowed down a bit in case. But the general recommendation is to escalate in case of inadequate response after 5 days of salumedrol. Then in case there is no adequate response again after a few days, after 2 weeks, say after initiation of corticosteroids, quick escalation to second-line immunotherapy, so rituximab. And then again, assessing the patients between 1 and 3 months after rituximab. If the patient isn't responding adequately, if there's no clear trend of improvement, then consider the escalation to cyclophosphamide. Then again, at 1 to 3 months after cyclophosphamide, if there's no adequate improvement, escalate to another agent such as tocilizumab. Here, there's a bit of a fine line between giving time to the patient and to the disease to improve, because we know that this is a slow disease to improve, and being aggressive and treating properly. Because, as I said, we need to understand the course of the disease, to understand how it's going, but also to be able to intervene when the response is not adequate.
Thank you. Thank you.
Yeah, Dr. Hassan, your comments, sir.
Thank you. Thank you, Margarita. Excellent presentation. I really enjoyed that. So my comment also about the treatment issue. Yes, in the pediatric spectrum, we see more cases with NMDA and autoimmune encephalitis. The other side is MOGAD-related encephalitis. There are rare cases between the non-NMDA receptor encephalitis, and also we clearly discussed about the seronegative group. My question about that, in the case, in the intensive care unit time, in the first period of disease, initial period, is there a therapeutic window to start the therapy with a combined therapy? Today, we use sequential therapy. We are waiting. You clearly mentioned that 1 week or 2 weeks. Sometimes we wait 1 week, sometimes based on the case presentation, sometimes we wait 2 weeks. Do you think this is in the future we are going to pass to do combined therapy? I mean, then combine the step 1 to step 2 together to start in the early phase of disease. For example, first week of the case in intensive care, the case who has poor prognosis, poor outcome.
Thank you for your interesting question. Indeed, I don't know yet, but certainly a combined approach, aggressive approach, is obviously more reasonable, is very reasonable and more supported in case of severe disease. If the patient is very severe straight away, goes into the ICU, of course, then the rationale for being more aggressive is there. And the same is in case the patient doesn't improve despite treatments, and maybe the patient's still in the ICU, he's still on ventilatory support, and he's not showing a trend of improvement, then I guess a more aggressive management is justified. But also, I have to say that regarding what you said, I've heard about some centers which are starting to give rituximab straight away. Diagnosis of an MDR, steroids and retux straight away. So this is a new trend in treatment, very interesting. And I guess with emerging evidences, we will have more data whether this improves the treatment outcome and outcome overall. In fact, we already know that timing and correct treatment, aggressive treatment, are important already, also for the final outcome and for the risk of relapse. Maybe this aggressive treatment will improve this even further. We don't know yet. I guess we're here to hear what happens.
May I just pitch in actually? Amazing talk, Professor Margarita. My one question is, Dr. Hassan was asking about tier 1 and tier 2 combination, right? But I am asking you, have you ever tried giving methylprednisolone and IVIG simultaneously in any patient, keeping some sickness in mind, or somebody you have planned a plasmapheresis followed by IVIG simultaneously? I mean, that will be subsequently, sequentially, I mean, without giving time. Or, sometimes there were some protocols in which some people were giving, like methylprednisolone in the morning and IVIGs in the afternoons, where, so what about your take on that?
Yes, I think in most clinical settings, methylprednisolone is actually associated very soon with other first-line immunotherapies. I agree with that. Also, depends, of course, on the severity. In our experience, most of the patients we had were sort of severe from the beginning. So I think it's completely okay. Of course, when we ideally, well, if we know that plasmapheresis tends to wash out IVIG, so ideally we shouldn't do IVIG and then plasma exchange if possible, and then plasma exchange again has a more quick action, but it can be more difficult to carry out. So either which one of the two, IVIG or plasma exchange, sometimes is a choice that depends on a lot of factors, as we said. But yes, I agree that very often they can be done together, IV methylprednisolone and IVIG or plasma exchange.
Thank you. Thank you. Vishnu, can you just go to the QA fast and see any questions to be asked which are not being answered?
Yeah, ma'am, I'll do that. So there's one question which asks, after how many days of IVIG plex can be done?
So IVIG half time is about 21 days. So that's when the IVIG in circulation decrease. But it depends on the clinical severity, because if we wanna do plasma exchange after IVIG, that means the patient is still severe. In that case, doesn't matter if IVIG are still in circulation. We need to do something and to escalate. Actually, in the protocol, in the recommendations, what suggested is that if the patient has already received 2 first-line immunotherapies, so for example, rituximab and IVIG, but still not responding adequately, then escalate quickly to second line, so to rituximab, rather than doing a third first-line immunotherapy. So if no adequate response after 2 immunotherapies, go straight to rituximab. But in case that is not available or there are contraindications and the patient is still severe, then cyclophosphamide can be considered, or in case therapeutic apheresis can be done too, even if it removes IVIG.
So there's one more question which says, what is the possibility that CSF NMD antibodies are positive and serum is negative? We usually see this after initially on treatment. So your opinion, please.
It can happen. So the CSF is more sensitive than serum. So it has better diagnostic yield, CSF. So antibodies should always be tested in CSF and serum, but it can happen that they are positive in CSF and negative in serum. It does happen. That's why it's important to do of course, the CSF test.
Yeah. So there is this question, do we need to continue first-line therapy for children needing second-line therapy? So I think it's more about continuing the maintenance steroid once they need second-line therapy, because anyway, second line will be started after the first line is exhausted. So I think it's more about continuing maintenance steroid. This is what I could make out of the question.
So first-line immunotherapy can be continued for immune modulation, so low-dose steroids or monthly methylprednisolone pulses or monthly IVIG, yes, especially if a little bit of benefit was observed. And this can be continued even when second-line immunotherapy is carried out. Probably starting rituximab, second-line immunotherapy, in a timely fashion, maybe it's more important, my impression, rather than carrying on with steroids. But yes, several centers use monthly methylprednisolone pulses or IVIG, for example.
So how frequent are relapses after MOGAD? Usually a low relapsing disease, but any data, do we have a concrete number, like what proportion would relapse?
Yeah, it's not relapsing in most cases, but up to 30, even 40% of patients can have a relapse, even in children. It was initially thought to be more frequently relapsing in adults, but there's data showing, of course, depending on the different cohorts, relapses go anywhere between 10 to 40%, even in children. So yes, it's been shown, although with only initial data that a prolonged oral corticosteroid taper for a few weeks helps reduce the rate of the risk of relapse after a first MOGAD event.
So what is the usual maintenance dose of IVIG in MOGAD? So it's 1 or 2 mg per kg. So again.
Well, there's not really a standardized dose, but I would say probably 1 would do, although this is very variable, I would say.
Then there is somebody. Yes, ma'am. Shifali ma'am, you want to make a comment? Yeah.
No, I wanted to say, can we have the rest of the questions answered online on Q&A when we start the cases, and anything left so that in the end we can take the others? And just one, can I ask you a question, Professor Margarita? In NMDA, what is the longest relapse time from the first case you've seen ever, I mean, in your practice thus far?
I'm not sure what's the longest ever, but we've had a few patients with NMDA receptor encephalitis, and one relapsed after 7 years, actually.
No, actually, one of my patients has relapsed after 14 years. That's why I'm asking.
Wow.
She just relapsed she just relapsed. She was perfectly fine. She was very, very bad to treat. Had to get plasmapheresis and everything done. So, but now she's relapsed at 16 and a half years. And after being well for 14 years. Yeah. So that's why it is a very amazing
Quite
condition.
Striking. Yeah, very striking.
Yeah. Thank you. Can you answer some questions online, Margarita, while they start the cases?
Sure.
Yeah, thanks. Vishnu, let the people be in, and please flag them at 5 minutes, please.
Yeah, ma'am. Yes.
And they have to finish at 6. Yeah.
Yeah. So can we start with the first case presenter? So we have Dr. Seda Kanmaz from Turkey. So can we have your case presentation, ma'am? Can we start?
Okay.
Yeah, we are able to see your screen. Perfect. Yeah.
Okay. Good evening. First, I would like to thank the Professor Chevalier for this fantastic special interest group session. I would like to present anti-HU associated encephalitis I would like to share our patient whom we have been following for 30 months and our challenging treatment process. A 2-year girl with normal development history referred to our emergency room with new onset focal motor seizure. By the video, you can see her segmental myoclonus affected the right arm and the trunk. She had right hemiparesis, mild ataxia, and irritability. With this slide, you can see the first day EEG, which show interictal sharp wave discharge in the left centroparietal region And with the video EEG, there is no electrographic sign of the myoclonus, so we evaluated it as a subcortical myoclonus. Brain MRI showed T2 hyperintense lesion compatible with encephalitis in the left parietal lobe. When we consider etiology of encephalitis, she has no fever and sign of meningitis. The possibility of an infectious cause was diminished. Lumbar puncture was performed, antiviral and antibacterial treatment was started. In addition, intravenous immunoglobulin was started without delay due to the suspicion of autoimmune encephalitis in the patient who had new onset focal neurological deficit seizures, segmental myoclonus, and irritability. Cerebrospinal fluid analysis revealed high polymorphonuclear leukocytes and EEG index, but protein and glucose levels were normal. Viral PCR and culture were negative. After infectious etiology was ruled out, we investigated immune etiology. This slide displays the autoimmune encephalitis panel research in our country. All of them were negative. Can it be paraneoplastic? With neoplastic screening, abdominal ultrasonography, and spinal MRI showed a left suprarenal mass, suggesting neuroblastoma. Neuron-specific NOLAS was high. The detected parietal lesion raised the suspicion for anti-HU encephalitis, and CSF anti-HU was 3 positive. When preliminary diagnosis of encephalitis was made, we had already started intravenous immunoglobulin. First and third date of the paraneoplastic encephalitis, dexamethasone was administered. The patient underwent surgery and the histopathology confirmed neuroblastoma. At the second week, there is an increase of myoclonus, weakness on the right arm and leg, and progression on the MRI. During this process, the patient was stimulously started on the cyclophosphamide, which is included in the neuroblastoma chemotherapy protocol. We know that cyclophosphamide was a very effective agent in anti-HU's encephalitis, which is an intracellular antigen. At this video, you can see her clinical regression as increase of myoclonus, weakness on the right arm and leg. And with this slide, you can see progression on MRI, hyperintensity on left parietal cortex and insular cortex involved at first month. So we started pulse multiprednisolone, intravenous immunoglobulin, and cyclophosphamide monthly. Second month, you can see her spontaneous movements. She is more strong. And fourth month, her MRI was normal, but we suspected of parietal lobe atrophy. I would like to draw your attention on our treatment chart. We go on monthly intravenous immunoglobulin, steroid, and cyclophosphamide. At fourth month, she could walk independently and use her right extremities. At the 6 months of therapy, myoclonic movements gradually increased and become continuous. The ictal video EEG recording of the case led to diagnosis of epilepsia partialis continua. There is a hemispheric asymmetry consisting of high amplitude sharp and slow waves that are more prominent in the parietal part of the left hemisphere. Due to the clinical picture worsening despite steroids, EVIC, and cyclophosphamide, rituximab therapy initiated. And the anti-HU antibody level in CSF was reassessed and it was found to remain high. Rituximab therapy revealed partial response. EEG findings were same. Her myoclonus going on. At the 18th month follow-up, we started tocilizumab. Now we are at the 30th month follow-up. She diagnosed as neuroblastoma, paraneoplastic encephalitis, anti-HU positive, right hemiparesis, global development level. You can see with this video, he can use her right arm, but she had mild hemiplegia. She is using 3 anti-seizure medication, levetiracetam, valproic acid, and sultian. We maintain tocilizumab 8 milligram kilogram banşa and in 9 cycles. Paraneoplastic neurological syndromes have various clinical syndromes. We diagnose our patient encephalomyelitis. Opsoclonus myoclonus syndrome is more common in children with neuroblastoma. Anti-HU antibody is intracellular antigen. Anti-WHO associated paraneoplastic neurological syndromes are generally seen in small lung cancer in adults, and anti-HU antigen is also positive in children with opsoclonus myoclonus syndrome with neuroblastoma. Anti-HU associated encephalitis has been reported in a small number of pediatric cases, with all having past history of opsoclonus myoclonus syndrome and neuroblastoma. Anti-HU associated paraneoplastic encephalitis may be the first manifestation of neuroblastoma. In this slide, a 4-year-old boy, stage 3 neuroblastoma, have confusion and seizures 6 months after the end of first course of chemotherapy. His MRI showed subcortical with patchy hyperintense lesion, diagnosed anti-HU encephalitis, pulse methylprednisolone started, and clinical improvement achieved in 2 weeks. He's diagnosed as relapse of neuroblastoma. Another 8-year-old case diagnosed mediastinal ganglioneuroma with long-term moderate headache. Regression in lesion was seen after surgery. Signs, the anti-HU is an intracellular antigen. Its treatment is more challenging and its prognosis is worse than other autoimmune encephalitis. Cyclophosphamide treatment has been highlighted, mostly in publications, includes adult patients. Tocilizumab presented more effective than rituximab due to it blocks all interleukin-6 signaling pathway and effective on plasma and T cells. Tocilizumab is offered as an effective agent in refractory autoimmune encephalitis, rituximab resistant neuromyelitis optica spectrum disorders, and MOG-associated disorders, NORS and FIRES cases. In a prospective study, it was reported that while 60% of patients receiving tocilizumab were well responsive, modifier ranking score less than 2, the rates were 22% and 20% in rituximab and no treatment group. They suggested 1 month follow-up is sufficient for rituximab failure, then tocilizumab could be initiated. In pediatric cases, tocilizumab presented as effective even if we started late, and it has fast onset of action. Tocilizumab effect is independent of autoimmune encephalitis subtypes. In addition, tocilizumab is effective in superrefractory status epilepticus, and tocilizumab could be started directly by skipping the second step. In summary, in patients with neuroblastoma with opsoclonus myoclonus syndrome, anti-WHO associated encephalitis should be kept in mind. Although rare, anti-WHO associated encephalitis can be the first manifestation of childhood neuroblastoma. Epilepsia partialis continua has rarely been documented in pediatric patients with anti-HU mediated encephalitis, and tocilizumab is effective if even we started late and independent of autoimmune encephalitis subtypes, and it has fast onset of action. I would like to thank to my mentors. Thank you.
Yeah, that was a very interesting case from SIG University, Izmir, Turkey. So comments from Dr. Sanem Yilmaz, who is also the moderator for this case.
Thank you and good evening, everyone. Thank you, Seda, for the nice presentation. This case was really a difficult one for all of us because little was known and little was present in the literature, especially about the diagnostic or treatment modalities. We wanted to present this case because we wanted to highlight that this case presented just like an encephalitis case, and we excluded the infectious etiology, and the autoimmune encephalitis panel was negative, but we couldn't definitely call her as a seronegative autoimmune encephalitis because there was something wrong, especially the myoclonus. So before calling a patient like a seronegative encephalitis, we should do all the paraneoplastic panels and all the malignancy evaluations. This was really interesting for us in this mean. And also the treatment decisions, tocilizumab was really successful for this case. So we should keep in mind the opportunity of tocilizumab and should think about our patients giving tocilizumab if they are unresponsive to the other well-known therapeutic modalities. Thank you. If you have any questions.
Yeah, thank you. Comments from any of our experts before we move on to the next case?
I think a very, very interesting case because, most of us do the extracellular antibodies and, which are directed towards the extracellular antigens and not to the intracellular antigens. I think part of it is also the costs, part of it is also the problem that it's a very rarely do you find these intracellular antibodies. But I think this case demonstrates that maybe in the case which is not responding and which is seronegative, maybe a good idea to do an expanded kind of antibody panel rather than just the routine extracellular antibodies. Thank you very much for this case.
Thank you, Raj.
Yeah, it was very nice. Very, very nicely done. Thank you.
So we can move on to the next case now. This is from Hinduja Hospital, Mumbai. Dr. Saheli Roy is the presenter and Dr. Neelu Desai is the moderator.
Good afternoon, respected faculty and all the attendees. I'm going to present my case, just sharing my screen. Myself, Dr. Saheli Roy, currently pursuing my pediatric neurology DRNB residency at PD Hinduja Hospital, Mumbai. My case for today is an intriguing tale of amnesia attributable to a treatable cause under the guidance of my consultant, Dr. Neelu Desai. So our patient was a 17-year-old adolescent girl, complained of some behavioral changes in the form of irrelevant talks, poor scholastic performance, and memory issues since last 2 years. Along with that, she also had complaint of paroxysmal events, very infrequent, once in a year. The first episode was very subtle, missed by parents. Second episode was a status epilepticus. Both were unprovoked. During the admission for second episode, an incidental hyponatremia was also detected. Birth and development was normal, and family history was not significant. Examination revealed normal orientation. Mini mental status examination was perfectly normal. Registration recall was normal, but the long-term memory was impaired. Speech was unaffected. Other motor examination, sensory and cerebellar science, everything was normal. Neuropsychological evaluation was done, which revealed an intact cognitive function with an IQ of 96, but impaired functioning in the tests of verbal and visual memory, with significant difficulty in remembering. The significant investigations were a raised ESR and abnormal EEG. In the form of bilateral centroparietal interictal discharges and intermittent right-sided frontotemporal slowing. Other tests like ANA, anti-dsDNA, thyroid, anti-TPO, homocysteine were all normal. So we went ahead with the MRI of this patient, and as is evident, there was some T2 and flare hyperintense lesions on the right insular and bilateral hippocampus without any contrast enhancement or diffusion restriction. Following this, CSF was done, which revealed a normal cell protein and sugar, but the oligoclonal bands were present, 4 to 10 number with negative serum oligoclonal band, and the CSF IgG was elevated. In view of limbic encephalitis, CSF and serum autoimmune markers were set. All the routine autoimmune antibodies turned out to be negative. MOG and NMO was also tested and it was negative. So in USG, abdomen and pelvis was done to look for any occult lesion, but none was detected. Following this, we went ahead with the PET scan, and it showed a mixed metabolic pattern with a hypermetabolic area in the frontal and bilateral mesial temporal lobes and hypometabolic elsewhere. Also, there was no evidence of any other PET avid lesions anywhere else in the body, practically ruling out malignancy. So we were at crossroads, and so thus patient, considering the condition of the patient, we also went ahead with the immunotherapy, stamping the patient as seronegative autoimmune encephalitis. But we also sent, in the meantime, the CSF and serum for the uncommon antibodies. Interestingly, during the steroid therapy, she developed a persistent hyperglycemia, which in future required a metformin therapy for around 3 months. Finally, serum and CSF anti-GAD antibody turned out to be strongly positive. And she was diagnosed with anti-GAD antibody limbic encephalitis. Patient was discharged with tapering dose of oral steroids and anticonvulsants. At 1.5 month follow-up, patient was seizure-free. She had some memory issues, residual memory issues, but had significantly reduced from before. And the repeat MRI scan also showed significant reduction in the lesions. Neuropsychological assessment was repeated after 8 months, which revealed improvement in the verbal memory, but the visual memory was still in the low average range, but that had also improved from before. At 1 year follow-up, recently she came, and she is seizure-free on antiepileptics. Her memory issues have absolutely resolved. She has picked up the scholastic performance, giving the 12th board exams, and hyperglycemia has also resolved. Repeat MRI and neuropsychological assessment was also advised, but had to be postponed because of her upcoming exams. So just a review of the condition, autoimmune encephalitis, as we know, can be antibody positive as well as negative. And out of the antibody positive, it can be against extracellular, intracellular, or against synaptic receptors. So our case, anti-GAD encephalitis, is an antibody against an intracellular antigen. So just briefly going through it, that it is relatively a very rare condition, more so in pediatric population, where in a largest number of pediatric GAD encephalitis reported in a particular study is 10. It has a sharp female predominance, and usually in adults. Etiology usually can be associated with some autoimmune disorders. Out of that, special mention is needed for type 1 diabetes. So in our case, we should be vigilant in future for the development of diabetes, because our patient had a episode of persistent hyperglycemia. And also it can be associated with some malignancies, which was ruled out in our case. Genetic predisposition can also be there. Coming to the clinical features, amnesia is the most common feature, followed by subacute onset seizures, confusion, behavioral changes, psychiatric symptoms, cognitive dysfunctions, and hyponatremia has also been reported in few cases of GAD encephalitis, as was seen in our patient. So, as we know, GAD can present with neurological as well as non-neurological manifestations. Out of the neurological, limbic and extralimbic encephalitis and refractory epilepsy are the most common in children. The other two, that is cerebral ataxia and stiff person syndrome, are more common in adults. Also, the CSF GAD antibody needs to be positive for any GAD-associated neurological disorder. Serum GAD positivity is not significant for the neurological conditions. And also, there is no correlation between the titers and severity or duration of the illness. But yes, studies have shown that the titers do come down after immunotherapy. CSF analysis shows moderate leukocytosis and mild elevation of protein with GAD antibody positivity and oligoclonal band positivity. MRI brain can reveal bilateral hyperintensities in the temporomesial structures, which in the later period of time can turn atrophic. PET scan can show a mixed pattern, hypermetabolism in some areas, particularly the mesiotemporal areas, hypometabolic in others, as was seen in our case. Treatment, the first line immunotherapies are the common ones, the intravenous methylprednisolone, IVIG, and plasma exchange. Second line being rituximab, cyclophosphamide, and MM. And interestingly, earlier the therapy started, better is the outcome. And also slow taper is needed because chance of relapse is high. Overall, the condition has a poor prognosis, though there can be transient improvement in initial 6 months. Between 6 months to 6 years, many patients develop refractory seizures, impaired cognition, and MRI reveals hippocampal sclerosis. So long-term follow-up is needed for our patient. Finally, my concluding message would be that in any case of subacute onset limbic encephalitis, apart from the routine antibodies like LGI, Casper, NMDR, GABA, AMPA, anti-GAD antibodies should also be thought of and should be actively searched for. With this, I would like to conclude my presentation. Thank you.
Thank you, Dr. Saheli, for that wonderful presentation. So can we have comments from Dr. Neelu Desai, who is moderator for this case?
Hi, again, this was a very intriguing case because though initially it looked like a limbic encephalitis, her initial biomarkers in the CSF for all autoimmune encephalitis were negative. So here it was the extended spectrum and the PET scan. I think I would really want to highlight the importance of a hypermetabolic PET scan, which helped us think that this was initially we thought it was seronegative until the extended spectrum of antibodies showed anti-GAD65 positivity, which helped us reach the diagnosis. And I think that helped us in further planning the treatment. However, though the initial improvement has been there, our fingers are crossed because the overall prognosis, especially in terms of the epilepsy, is not very good in this condition. And another thing which we are still not sure is how long to continue the immunotherapy, because right now we are awaiting her 1-year scan and IQ and memory reports. So maybe we'll plan for the treatment. In fact, I would want to know from the experts how long should we give the immunotherapy right now, because there is no clear guideline how long to give it. So I think we thought we'll await her memory tests and her maybe a repeat PET scan we'll do. Once her exams are over, she'll come back. So that's what is planned.
Any comment from the experts?
Yeah, Vishal, I have a comment. Yeah, it is a nice case, and then they clearly demonstrated the PET abnormalities located on the mesial temporal area. Is it also compatible with the MRI abnormalities?
Yes, it is.
It is. Yeah, thank you so much. I suspected that it might be related to the seizure activity arising from the mesial temporal area, maybe status epilepticus may cause it, but you clearly mentioned that this is compatible with your MRI and PET abnormalities compatible with on the same side.
Yeah. Only thing is the seizures are very infrequent. So she had, I think, only 2 or 3 seizures. So this was not an ictal PET which was there. It was an interictal PET.
It's great. Thank you.
So we have a comment in which they said that we have serum from Dr. Vishwanath, which said we have serum positive antibodies with PET scan showing suspected lymphoma in a case of GAD65 encephalitis. There is one question. The question is, what was HbA1c, serum insulin, and C-peptide level from Dr. Bijay?
Yeah, these were, I think, done, and they were all I think Soili may answer this. They were all normal. It was endocrinologist was referred.
It was a transient condition, so it was normal as like it started only after the methylprednisolone treatment was started, but it persisted for long, and values of sugar values were above 200 and even reached up to 300. It was persistent even after stopping the steroid. So that's why the metformin was considered, but other things were normal.
Okay, thank you. Any further comments, or do we move on to the next case? Okay, so if there are no further comments, we move on to the next case. This is from Government Medical College, Trivandrum. Dr. Reshmi Ashish is the presenter, and Professor Mary Aik ma'am is the moderator. So we move on to the next case now.
Good evening, respected faculty. I'm Dr. Reshmi Ashish from Government Medical College, Trivandrum. I will be presenting a case of IH which was not idiopathic. Our child, Merciless, he's 12-year-old boy, second born to non-consanguineous marriage with no significant past history. He was developmentally normal. On 26th October morning, he was found unresponsive at his home on floor with drooling. And later, child had recollected that sometime after waking up, he was unable to move his left hand. And when he tried to manipulate his left hand with the right hand, he was still unable to do that. And following this, he felt dizzy and he fell down. And for this, he was taken to medical attention, and his MRI brain was done, which was normal, and EEG also was done, which was also normal. About 2 weeks later, on November 9th, he had presented again with a bifrontal headache and fever for 2 days. And next day morning, he had again one episode of dizziness, which was followed by focal seizure with impaired awareness, characterized by deviation of head to one side and bilateral upper limb posturing, which lasted for about 1 minute, which was followed by multiple episodes of vomiting. And he became unresponsive. And the child was taken to our ER, where he was found to have poor sensorium and poor respiratory effort, and he was intubated. And on examination, he was overweight. His vitals were within normal limit. He had bilateral papilledema. His vision was normal, and other cranial examination were normal. He had normal tone, power normal, and deep tendon reflexes were brisk with bilateral plantar flexor. And on his blood investigation, he had neutrophil leukocytes with a total count of 31,900. And also other inflammatory markers were elevated with a CRP of 2 and ESR of 80. And his peripheral smear was done to look for reticular cells, which had shown only normocytic normochromic with a neutrophilic leukocytosis picture. And his LFT and RFT also were normal, with electrolytes were also normal. In view of his weight, his fasting lipoprofile was done, which was also normal. And since he was presenting with a recurrent episode of dizziness, his ECG, Holter ECG also was done, which were both were normal. And second time around, his EEG had shown moderate degree of generalized slowing, but it could have been probably due to postictal slowing. And his second repeat MRI was done, and which had shown bilateral prominent perioptic spaces and posterior scleral indentation, which was suggestive of raised ICT. But there is also some non-specific sulcal hyperintensities along the lobes, which they have suggested probably secondary to the altered hemodynamics. Hence, we went on to do his CSF study, and his opening pressure was found to be high with 42 centimeters of mercury of water, and rest of CSF study was normal with no cells, and protein sugar were normal. And his visual field charting was done, which have shown only scattered scotomas, and MRV done to look for venous sinus thrombosis was also normal. So a professional diagnosis of idiopathic intracranial hypertension was considered, and he was started on diamox, and he went on to become asymptomatic and was discharged after 1 week. And about 2 weeks later, on 24th November, he again presented with 1 day history of low-grade fever and severe headache and vomiting for 2 days. For this condition, he was admitted, and 2 days after admission, he started complaining of pain over his left eye. On examination, his vitals were stable, but he had RAPD over the left eye with persistent bilateral papilledema, and he had only light perception left on his left eye for visual acuity, and his right eye had 20/50. No other focal neurological deficit was found, and he had neck rigidity at this moment. And his blood investigation had shown a persistent neutrophilic leukocytosis with a total count of 24,400 with a persistently high elevated inflammatory markers. His ANM screening was done, immunofluorescence was done, but it was negative. His repeat peripheral smear again was normal, and his RFT, LFT, and serum electrolytes were again normal. So now we have a child with acute painful loss of vision on left eye. Since he was already having IH, we first thought of malignant progression of the IH, and we repeated the CSS study, which was again opening pressure was found to be high of 40, and a 25 ml of CSF was trained. And at this moment, in view of the painful vision loss, we thought of other causes of optic neuritis like demyelination and infective etiologies also. And to a slight surprise, the total count was found to be 293 cells per millimeter cube, which was lymphocytic with a 47 sugar, which was around 50% of the GRPS. We went on to do the CSF CBNet, which was negative. CSF cytology was also done, which was also showing a normal picture. Culture and sensitivity and CSF viral panel also were done and negative. And third time, his MRI was repeated, which had shown paramedian parieto-occipital hyperintensities and left medial, paramedial left lobe cortical and subcortical hyperintensities also were there, and cortical, subcortical hyperintensity along the medial aspect of bilateral temporal lobes could be seen in the first image. In the middle image also, paramedial frontal cortical, subcortical chiral pattern hyperintensities we could appreciate. And in the third picture, there is bilateral optic nerve hyperintensity, T2 hyperintensities with the swelling of the left optic nerve. There is optic nerve neuritis more on the left side. And also there was diffuse leptomeningeal enhancement. So, after the MRI picture, diagnosis of meningoencephalitis probably associated with anti-MOG antibody or tuberculosis was considered, and his VEP was done, which was shown inconsistent waveforms over the left eye and prolonged p100 latencies of the right eye. And we have started him on ceftriaxone injection vancomycin and empirically on ATT, and NMO-MOG also was sent, and it had come positive with 1:10 dilution. MRI spine screening was done, which was also normal. He was started on injection methylprednisolone and IVIG 2 gram per kg also was given. By day 5 of methylprednisolone, his vision had improved to 20/20 and ATT was stopped. So this is the timeline of the child. On 26th October, he had presented initially with a seizure, and that time MRI and EG were done were normal. And 2 weeks after, again he had presented with the fever triggered seizure. Again that time MRI was suggested only of IAH, and it took around 1 month from the disease onset. Only on November, his MRI had picture suggestive of had shown something that is MOGAD features like meningoencephalitis like features which could be associated with the MOGAD was seen only after 1 month of the disease onset. There is a case report that was published in the Neuroimmunology Neuroinflammation of a 19-year-old woman who had MOGAD with relaxing remitting IAH presentation, but this lady didn't have optic neuritis. And this is some MOGAD where MOG associated encephalitis, where we could see on the right side post contrast enhancement, and in the left we could see the cortical chiral pattern, cortical hyperintensity to hyperintensities, and the bilateral optic neuritis. In the right top picture, we could appreciate the post-contrast enhancement along the longitudinal extensive post-contrast and enhancement along the optic nerve sheath, which could be seen even before the optic nerve T2 hyperintensities. A similar picture could also be seen associated with tuberculosis, whereas it is usually seen as very thin, smooth post-contrast enhancement along the optic chiasma and along the basal systems. Also, there could be post-contrast enhancement, and the evidence of arachioniditis and tuberculoma also could be looked for. And another factor is elevated neutrophil to lymphocyte count, as we have seen in this child, which has a correlation with the activity of MOGAD. In a series of 62 children, they have found out that this neutrophil to lymphocyte, elevated neutrophil to lymphocyte count has ratio has correlate with the disease activity in MOGAD. It is usually elevated in all of the inflammatory demyelinating diseases, but in case of NMO, it is seen elevated during activity and in remission, but in MOGAD, it is usually active. It is elevated only during the activity, so it can be an indicator of activity in MOGAD. The take-home messages we would like to are when there are atypical features present associated with IAH, we should evaluate further for secondary causes, and you can consider MOGAD also. And MRI could be negative even after the symptom onset in MOGAD, and neutrophilic leukocytosis could be an indicator of MOGAD disease. Thank you.
Thank you. Dr. Mary, can you give a brief comment? We are running actually 12 minutes behind schedule. Dr. Mary? Yeah, please.
That was
Your
a
comment.
case that we could diagnose actually with great difficulty. We did not expect it to be MOG. When the antibody came as positive, actually, though we had read about it, we were surprised. And the result was amazing. Thank you.
Yeah. Thank you so much. It was a very nice case. Professor Margarita, can you make your comments on the last 3 cases, or else this case?
Sure, very interesting cases. This last case is one of the new emerging, recently described phenotypes of MOGAD that we didn't mention before, but it's been increasingly described in the literature, and it's important to keep in mind because it can benefit from immunotherapy indeed. Yes, and as was previously said, it's very important to test a wide array a wide panel of antibodies, including onconeural antibodies, that is antibodies to intracellular neuronal antigens, not only to surface neuronal antigens, because they're very rare in children, but they can occur, of course. And in general, in this disorder, since they're rare, since they're they have specific features in children, since there can be comorbidities, it is very important to rule out differential diagnosis, of course. So keep in mind neoplastic etiologies as well, metabolic causes, toxic causes, and other differentials that are of utmost importance to exclude, of course.
Yeah, I know we are running very beyond time. Dr. Margarita, there are two more cases actually left. Would you be able to join for 12 minutes, or you will have to log off?
Sure.
I mean, can you, 12 minutes, you'll be there? And
Yeah,
then I'll
sure.
ask you to request you to give take-home messages to everybody for the end. Take-home messages from your vast experience and all the guidelines you've been making. Thank you. Can we have the next case, Bishrup and Dr. Tipu, Dr. Udari, you want to add anything? As
So
the next...
just a point that we had actually reported, this patient had fever for a few days. Was it, we had reported about 12 children with a febrile illness. Initially may have presented with seizures, I think 3 or 4 did. And some of them only had a leukocytosis, like a meningitis presentation, and some had only seizures. And then later, and the MRI was normal, and they had leukocytosis as well as a high ESR or CRP. And later, ADEM came up on the repeat MRI. So sometimes the fever lasted for almost a month. So I think this is very similar to that. We reported this in 2020.
Dr.
Okay, so
Tipu?
we had other children like that, but this child did not have right.
Yeah.
Dr. Tipu, you want to add something? Go on to the next patient. Bishrup, pass.
Yeah. So Dr. Purbasha and Dr. Hansa, now it's your case. Yeah.
Requesting to stick to 6 minutes, please, so that we have both the cases in 12 minutes. Yeah.
Thank you, my respected teachers. I'm Dr. Purbasha from NIMHANS. Today, I'm going to be presenting a case, a treatable familial leukoencephalopathy, masquerading as a case of CNS demyelination under the guidance of Dr. Hansas ma'am. So my patient, 13-year-old child from Andhra Pradesh, he presented with recurrent neurological illness starting from August 2016, 2 episodes, and each episode was precipitated by a febrile illness. So coming to the case details, he presented to us in May 2023. He was a 13-year-old boy with normal development. He presented to us with a history of progressive walking difficulty with imbalance, and it was precipitated after a febrile illness since 8 years. He was apparently well till 5 years of age and has average scholastic performance. When in August 2016, he had an episode of fever. It lasted for 2 days. And after that, he has noted to have acute onset, gradually progressive, swaying on either side while walking, mild difficulty in negotiating through narrow pathways, but there was improvement of the symptoms over the next 10 days. So no specific treatment was given to him at that time in view of spontaneous improvement, and there was no residual deficit at that point of time. From the same time, the patient also developed some slurring of speech with progressive slowing of handwriting. He was managing with this difficulty till April 2023 when he had the second attack. At that time, he had fever with jaundice and thrombocytopenia, following which his condition progressively declined with the recurrence of unsteadiness while walking and with slurring of speech, and there was also inability to walk independently without support. Negative history, there was no history suggestive of any craniobulbar involvement, no tremulousness of lip, no weakness, no sensory symptoms, no history of any cognitive or behavioral changes, bowel or bladder disturbances, and there is no similar family history. Based on his clinical features, he was evaluated outside. One MRI was done, but unfortunately the films were not available. It had shown extensive symmetric subcortical and deep white matter involving the pons and the cerebellar white matter with few hemorrhagic foci. They have reported it as demyelination, bar metabolic post-infective. One genetic report was also done at that time. It showed heterozygous variant of uncertain significance in VAMP1 gene. inherited in autosomal dominant fashion in exon 4 of chromosome 12. Birth history was uneventful, and family history, she was firstborn of third degree consanguinity was present in this child. Developmental, he has achieved all the appropriate developmental milestones according to age. When he presented, he was currently pursuing he was currently studying in 7th standard. Immunization history was as per date. Examination was height and weight was somewhat less than third percentile. Systemic examination, CVS and respiratory system was normal. However, per abdominal examination revealed splenomegaly. Coming to the CNS examination, his visual acuity fundus were within normal limit. Extraocular movements were full in all directions. However, there was presence of gaze-evoked nystagmus. No facial weakness, rayness, both eyes, both ears. Air conduction was more than bone conduction. Wavers was centralized. Absolute bone conduction test, on left side, it was less than the examination. Same was with the Schwabach's test as well. He also had scanning dysarthria at that point of time. Coming to the motor examination, tone was normal to decrease in all four limbs. Power was 5 by 5 in both proximal as well as distal group of muscle in all four limbs. Sensory was normal. Rhombus stress was negative. He had generalized areflexia in all four limbs. There was bilateral finger, nose, finger and heel knee test was impaired. He had wide base ataxic gait. Coming to the summary, so this 13-year-old boy, premorbidly developmentally normal with average performance in the school, presenting with recurrent and progressive ataxia and precipitated by febrile illness. Neurological examination showed bilateral gaze-evoked nystagmus with left-sided mixed hearing loss and bilateral cerebellar signs were present with global areflexia along with systemic examination showing splenomegaly. So coming to the case analysis, it was a case of relapsing remitting neurological illness, query neuroinflammatories involved, localizing to pancerebellum and left eighth cranial nerve. So possible etiologies that we have kept. First, we have kept is demyelination, multiphasic edema, multiple sclerosis. Second possibility we have kept as CNS vasculitis. Third as metabolic encephalopathy, late onset urea cycle disorder, Lake syndrome, leukodystrophies, infiltrative CNS neoplasm bar HLH. Investigations that were done in our hospital revealed pancytopenia with microscopic hypochromic pictures. LFT, RFT, vitamin B12, and TFT were within normal limits. Serum ferritin and lipid profile, it was repeated 3 times, but it was within normal limit. Other biomarkers, ammonia, lactate, TMS, and urine for abnormal metabolites, all were within normal limit. Pure tone audiometry revealed left moderate sensory neural hearing loss with absent waveform on BERA on left side, but right side was normal. SSCP was normal and heart echo was also normal. USG abdomen shows moderate splenomegaly. On MRI we have done it. Next possible investigation was MRI. It shows in the supratentorial cut some asymmetrical hyperintensities in T2 flare as well as in flare in these are present in the periventricular region. Coming to the infratentorial cut, the cerebellum looked dirty with patchy asymmetrical lesions involving the MCP as well as SP, superior cerebellar peduncle as well as middle cerebellar peduncle, which showed contrast enhancement, and there was also some hemorrhagic foci in the cerebellum as well. So next possible investigations, we did the stereotaxic biopsy because of the site of lesion was more prominent in the cerebellum. It showed lymphohistiocytic lesion, which was admixture of polymorphous populations of mature lymphocytes, which was positive for CD3, CD138, and CD68. It was actually suggestive of a lymphohistiocytic picture. So we went with the next possible investigations, that is a genetic test. At that time, then the genetic test came out as a familial hemophagocytic lymphohistiocytosis type 2 due to PRF1 gene mutation. It is inherited in an autosomal recessive fashion and it is a pathogenic variant. So the final diagnosis for our patient was it is a case of PRF1 gene associated familial hemophagocytic lymphohistiocytosis type 2. Coming to my discussion, it's actually a hemophagocytic lymphohistiocytosis is actually a non-malignant disorder of immune regulations characterized by hemophagocytosis within the marrow and uncontrolled activation of the immune system in the form of activation of T cells, macrophages, and overproduction of the inflammatory cells. It is actually classified into 2 parts by primary and secondary. The primary HLH is also called familial HLH. It is caused by biallelic mutation in the genes involved in the secretory lysosomes dependent exocytosis pathway. This familial HLH is also classified on various types. Mainly currently 6 classifications are there. Secondary HLH is more prominent among the elderly population. It is mainly a sporadic disease. It develops in context to infections, malignancies, rheumatic disease, chemotherapy, or transplantation. In a setting of rheumatological conditions, secondary HLH is referred to as a macrophage activation syndrome, a potentially a life-threatening complication of systemic inflammatory disorders, and it is dominant by overwhelming inflammation. HLH diagnostic criteria, based upon the 2004 criteria, it is mainly of two types. Two categories are there. Genetically proven it can be done, or clinical features. 5 out of the 8 possible clinical features should be positive. Among them, fever, splenomegaly, peripheral blood cytopenias, hypertriglyceridemia or hyperfibrinogemia, hemophagocytosis, mainly in the bone marrow, spleen, lymphoid organs, and in the liver, low or absent NK cell activity, ferritin more than 500, elevated soluble CD25. In our patients, only 3 criteria were fulfilled. The patient had splenomegaly, peripheral blood smear showed cytopenia, hemophagocytosis was present, but it was present mostly in the other tissues like the brain tissue, that from which the biopsy was done. CNS features, the definition of the CNS disease in HLH has not been standardized. Evaluations for possible CNS involvement in HLH rest on 3 specific areas of investigations: the presence of neurological signs or symptoms, neuroimaging abnormalities, and evaluation of CSF. Usually, HLH manifests as a multi-system syndrome. Isolated CNS involvement in HLH preceding systemic manifestation is a rare phenomenon. CNS manifestations can be varied. It can range from features of meningitis like neck stiffness, irritability, coma, hypotonia, hypertonia, seizures, multiple cranial nerve palsies, ataxia, as we had in our patients, hemiplegia, quadriplegia, visual impairment. Radiological features is a very important criteria to diagnose HLH. So it is important to see both the supratentorial as well as the intratentorial cuts, as in our patients. Normally in all of the patients which studies have been done, it will show some hyperintense lesion involving the cerebellum, the brainstem, mainly the cerebellar peduncles. It will be patchy. It will be a dirty looking cerebellum. It will show T2 hyperintensity as well as contrast enhancement. Multiple hemorrhagic foci can also be there in the.
Can you wind up? Next 30 seconds.
Yes, ma'am. Treatment mainly etoposide is given as an induction therapy and followed by dexamethasone. Continuation phase, dexamethasone is given and etoposide, and the main line of treatment is hematopoietic stem cell transplantation. So take-home message is it's a rare treatable neuroinflammatory syndrome. High index of suspicion is required for clinching the diagnosis. Isolated CNS involvement preceding the multi-organ involvement is rare. Often it is misdiagnosed as a case of CNS demyelination, clippers, or lymphoma. Radiological hallmark I have described previously. Treatment mainly includes etoposide induction therapy with steroid, followed by hematopoietic stem cell transplantation. Our patient is currently undergoing, was given etoposide induction therapy, followed by steroids, and she has currently undergone hematopoietic stem cell transplantation and is currently under treatment in new oncology department of Andhra Pradesh College. Thank you.
Yeah,
Thank you.
Dr. Yeah.
Hansa.
Yeah, Dr. Hansa.
Actually, most of these cases we end up diagnosing as primary CNS demyelination. It's very important to consider this differential when the treatment is not appropriate, especially when you have a radiological finding with the dirty cerebellum, what she showed, with punctate or nodular enhancement in the cerebellum. So it's a marker to suggest it's not primary CNS demyelination, it is something else. It's another neuroinflammatory syndrome. And other things, only isolated CNS involvement without multisystemic involvement is very rare, and we have to have a high index of suspicion for diagnosing the same. Thank you.
Thank you. Professor Margarita?
Thank you for this very interesting case. This is a very important differential diagnosis to keep in mind, especially as you said, sometimes the disease can have no systemic signs and symptoms, but only a central involvement, central nervous system involvement. And it can be a very severe disease. So it is, and the course is very different to the usual neuroimmunology and demyelination diseases. So it's very important to diagnose it early and treat it appropriately.
Thank you. Dr. Udani, Dr. Tipu? Dr. Tipu?
Yeah. I think it's an extensive and elaborative account of the management and the varied clinical presentation of different neuroimmunological disorders. And again, once again, grateful to Shifali for your excellent organization and putting all these clinical cases together, and subsequently quite extensive discussion as well. So again, my question would be to the main speaker regarding the experience of rituximab versus cyclophosphamide and mycophenolate mofetil. In your experience, how the clinical response varies when we select out of these three as a tier 2 or tier 3 immunomodulator in case of resistant patients with NMDR or autoimmune encephalitis. So in case of failure to get the optimal response with the solomedrol, IVIG, or maybe the Plex, can we switch immediately from this tier 1 to either mycophenolate mofetil or maybe cyclophosphamide, and the response in these resistant cases? Margaret.
Currently, the recommendation for second-line immunotherapy is mostly for very severe cases, or for cases that do not respond adequately to first line. But as I said earlier, there is a bit of a trend to use second line earlier in the course of disease. So I guess at some point it's a bit of a clinical decision making depending on the individual patient. So in case of very severe disease, I guess a more aggressive treatment protocol is.
But wondering, Margaret, about your experience, because in resource-limited countries, many times you are not very comfortable in prescribing and using these relatively expensive medicines like mycophenolate mofetil. So what we are mostly prescribing or using maybe Imuron.
What is Imuron?
Imuron is
azathioprine.
Azathioprine. Azathioprine.
So yeah,
which is relatively cheaper. Which is a relatively cheaper option for us. So what's one thing about your experience of mycophenolate mofetil and the relatively new immunomodulators?
So MMF, mycophenolate, is mostly used in NMDA receptor encephalitis, but azathioprine is used by some, and it's certainly used in other neuroimmunological conditions such as MOG-associated disorders. And we don't really have data comparing azathioprine and mycophenolate. So I think in case mycophenolate is not available or is contraindicated, or it cannot be prescribed at a certain center, but a maintenance treatment is still indicated, then I think azathioprine can be used as well with the same significance of maintenance treatment. As I said, maintenance treatment is usually necessary only in case of relapse or in case of severe disease. So most of the cases don't need it really. But yes, I think azathioprine could be a valid alternative.
Thank you so much. I think we have gone 30 minutes beyond time, but I will request for another 5 minutes because one student is ready with the case, and I think it is not going to be justice for that person to be presenting. Can we have the next case, and can I request the person to please finish in 6 minutes? I don't want to tell you lesser than that because it will not be right on my part. But yeah, really thankful for everybody for your time. Yeah.
Yes, ma'am.
Yeah, please. Yeah, Sandeep, fast. Yeah.
Yes, ma'am. This is a case who was a 15-year-old male child who was primarily normal, came with a presentation of fever for 2 days, severe headache and vomiting for 1 day, difficulty in walking, and a left focal seizure, which also had within a span of 1 day. He was admitted for the same at a nearby hospital and had multiple episodes of seizures with intermittent posturing, and thus noticed to have paucity of movements of the left side of the body. And there was also further deterioration in the form of altered sensorium, posturing, progressing to irregular breathing, requiring intubation and referred. And all these events happened over a period of only 2 to 3 days of onset of illness. And on examination in our hospital, he had a vitals, which was pulse rate was normal, or mechanical ventilation, BP was normal. His DCS was E2, VT, M4, and pupils were bilateral, equal, and reactive to light. He was stuporous and was same GCS wise. Fundus were normal, dorsal was intact, and the left human facial palsy was noticed, and gag was intact. On motor system examination, tone was bilateral upper and lower limb hypotonia, which was more on the left compared to the right. The power wise left upper limb and lower limb had positive with compared to the right with a power of almost 3 minus on deep extensive pain. Reflexes wise, both upper limb and lower limb was deep tendon reflexes were brisk with a plantar bilateral extensor. There were no other involuntary movements and no other nystagmus in any other movements noticed. So the initial possibilities considered was it was acute febrile encephalopathy with left hemiparesis and left human facial nerve palsy. So the differentials initially because of the acute presentation with the fever, we had initially thought of acute encephalitis to have been viral or autoimmune. The points favoring were fever, seizures, and poor sensorium, which relatively against was a focal deficit was asymmetrical, no behavioral change and no involuntary movements, and it was very acute. Second one was a vascular etiology with stroke of right NCA territory because of seizures and hemiparesis, but points against was fever, the extent of prolonged altered sensorium. Third was the ICSOL with cause of headache, vomiting, seizures, but acute presentation with fever was relatively not so specific. And demyelination was the last possibility, one of the possibility with fever, altered sensorium, but it was a relatively asymmetric focal deficit was present. So when we went with the investigations, as the fundus revealed no papilledema, CSF analysis was proceeded with. It showed leukocytosis with 140 cells, predominantly lymphocytic. Protein was 110 milligram per deciliter. Sugar was normal. And other infective panels by CSF BioFire and TB PCR was done, which was relatively negative. IgG index was positive. Oligoclonal bands and CSF anti-NMDA antibody receptors were negative. With respect to the serum, initial investigations were relatively normal. Proceeding to infective etiology, Brucella and Leptospira etiology was also done, which was negative. Serum anti-NMO and serum anti-MOG antibody, which was also done, was negative. Going to the neuroimaging findings wise. So the T2 flare axial cut revealed a perirolandic slash lesion involving predominantly the perirolandic region of the right hemisphere, predominantly involving deep white matter and extending into the subcortical white matter with corresponding diffusion restriction changes. And also there was middle cerebral peduncle involvement in the lower cuts associated. And importantly, there was also there was no significant perilesional edema, but there was significant edema to cause ipsilateral ventricular compression as well also minimal midline shift to the left side. And contrast enhancement on contrast lesions, there was minimal contrast enhancement in the predominantly sulcal spaces on the side of lesion, but there was no obvious ring-like enhancement, which was definitely seen, and there was no intra-lesional contrast enhancement. And also was the same was in the sagittal view, and screening for spine as well also the optic nerves were done, which were relatively normal. So the further course, so initial possibility of a demyelination was considered because of the presentation. IV methylprednisolone at 30 milligram per kg per day was given over 5 days, and there was no significant response that IVIG was given. And prolonged post-IVIG minimal response was noticed. He was able to position to be extubated, but post-extubation also the encephalopathy persisted for a prolonged period without any associated autoimmune or behavioral changes. Thus, neuronavigation guided biopsy of the lesion under general anesthesia was performed to rule out any possible neoplastic possibility. And the sections revealed a reactive glial tissue with diffuse infiltration by foamy macrophages, focal perivascular collection of macrophages, and a few lymphocytes were seen. And the stain was positive for GFAP, glial fibrillary acidic protein, and CD68, and which Ki67 proliferative index, which beyond 2% is indicative of high-grade proliferation, and less than 2% is indicative of low-grade proliferation, and relatively less likely for neoplasia. Thus, the child was continued on oral steroids with gradual tapering over a period of 4 to 6 weeks. On follow-up, after 4 weeks, the GCS was 15 by 15. There was independent walking and mild dysarthria alone, which was the lesions which are persisting. So this is mainly to try to highlight the presence of a tumefactive lesion, which can also present as a demyelinating pathology. So just points favoring for MRI, a large lesion with little mass effect and edema, a ring or open ring enhancement, which is seen on contrast. Central dilated veins within the lesion can be seen usually. On perfusion studies, there might be reduced perfusion, and they usually show rapid resolution after steroid therapy. Non-specific findings including minimally increased diffusion as in our case, tumor-like spectrum on MRS, and associated corpus callosum like involvement features also. The biopsy findings in usual demyelinating lesion are there are preservation of axons, which are shown by presence of neurofilaments, loss of myelin by negative Luxol fast blue staining, which might be helpful in neoplasia, and presence of astrocytic proliferation shown by presence of glial fibrillary acid protein, as in our case. Thank you.
Thank you so much, Harsh.
Yeah.
Sorry, Bishrup,
Thank
I
you.
was
So
doing
this,
fast forward. I was just trying to wind up. Sorry. Harsh,
Perfectly
please.
fine,
No,
ma'am.
you
Perfect.
take your time. Yeah.
yes, yes. This case was challenging a bit in form of presentation with consecutive seizures, few episodes, and prolonged encephalopathy was persisted even after the immunotherapy. So we went ahead with the biopsy, and the biopsy was shown there is a pathophysiology of demyelination. In this, the MRI has shown the contrast enhancement, which was radical linear enhancement along the perivascular space, and the biopsy was showing increased enhancement of GFAP. So although we don't have a serological marker of glial fibrillary protein acid, which is a diagnosis for anti-GFAP encephalitis, but in view of upregulation of GFAP, usually in astrocytopathy, other than the anti-GFAP, there is a loss of GFAP and there is a loss of NMO in the form of, because there is the NMO targeted astrocyte food process, while the GFAP is an intracellular protein. So whenever there is a lysis of the astrocyte, there is upregulation of GFAP. So likely our case has anti-GFAP mediated encephalitis, and which was responded well to the immunotherapy. Thank you.
Thank you, Professor Margareta, Dr. Udani, Dr. Tipu.
Thank you, everyone. Very interesting cases with showing very different conditions, even within neuroimmunology, and not only. This shows how difficult the diagnose and the management of these cases can be, and how difficult it can be to diagnose these cases in at the initial stage, especially where there can be overlap with so many other conditions. It's important to keep an open mind, to know these conditions, so we're going to be able to see them, and to keep an open mind, keep differentials in mind, and also discuss with other colleagues when we're not sure, when something's not right, when the patient's stuck and they're not managing to improve properly, in order to verify the diagnosis, carry out further investigations when necessary, and use other treatment strategies when the patient is not improving adequately.
Thank you so much. I think 2-3 questions were unanswered. Bishrup, you want to ask 2-3 questions which have come repeatedly? Just fast so that we wind up in 2 minutes.
Yeah. Professor Nasadini, there are some questions which have been there for you. Primarily, these are contentious issues. I think partly you have answered. So one is, what is the duration of long-term immunomodulation in those who require long-term immunomodulatory therapy?
So the duration depends on a few factors, including disease severity, disease course, whether it's monophasic or relapsing disease, mostly. So, and treatment response, of course. So in patients who have a relatively mild disease, monophasic mild disease, treatment can be as short as a few months, say up to 3 months max. But if a patient is refractory or relapses, treatment can definitely be about 2 years long. After starting maintenance immunotherapy, for example, after relapse, of course, the data is very limited as to how long it should be carried on. Generally speaking, maybe if the patient is stable after 2 years of maintenance treatment, it can be overall between few months in very well-responding cases, 1 to 3 months, up to 24 months or longer in case of further relapses, of course.
You're muted, Bishrup.
So many of them, want to know your opinion regarding 2 things. One, whether they should start long-term immunomodulation after first episode of MOGAD with 30 to 40% relapse chances. And secondly, what would you prefer at your center? An acute episode you want to treat sequentially, or you want to go intensive, as the current trend is, giving a lot of immunomodulators at the same time, depending on the severity. So these 2 things.
So the current recommendation as regards MOGAD is not to use maintenance immunotherapy after one event, after the first event in case of monophasic disease. But of course, data are emerging, and maybe the recommendations will be updated with different recommendations later. One exception that is already there anyway is that if a patient has only had one with MOGAD patient has only had one event, but hasn't recovered properly after the first event. For example, he had an optic neuritis, but he still cannot see properly. Then the possibility of a further event would be could be very devastating on his visual outcome. So in that case, although he has had only one event, but he has the recovery is not complete, so it's still severe, then maintenance immunotherapy should be considered strongly, despite it's a monophasic disorder. And then, yeah, as I said, maybe later on there will be recommendations to use maintenance immunotherapy even after first event, but we don't know yet. Certainly now, use of corticosteroids, oral corticosteroids, taper is already recommended after first event for about 3 months. So even in monophasic disease. And as regards an NMDA receptor encephalitis, I think in most cases, well, what we would do and what most centers would do would be to start methylprednisolone and another first-line immunotherapy, such as IVMP and the plasma exchange, nearly simultaneously, or just one after the other, straight one after the other, or overlapping, it doesn't really matter. And evaluate the outcome after a few days, and if not, the recovery is not adequate, go straight to rituximab. Overall, I'd say people tend to have a low threshold for escalation in NMDA receptor encephalitis, at least up to rituximab, of course.
Thank you so much. I really thank you from the bottom of my heart for all the attendees side, and it was an amazing talk and amazing, discussion. Would you like? And I want to thank all the presenters for their wonderful cases and their moderators and the experts to have joined in. Can you give some any take-home message you want to give to all these attendees? And at this point, when we are actually 45 minutes beyond the time, and we still have 109 attendees at this point of time at 45 minutes beyond time. Want to give any messages? You understand that we understand that you are the best person speaking on this topic, and the topic is so important and we face in common practice. So any take-home messages, final message from your side?
Thank you, everyone. It was really interesting. It's important to keep talking about this because these conditions are rare, but when they happen, we want to know to be able to recognize them and to treat them. So joining experiences is very crucial, as well as joining data in order to provide and to create meaningful results and data that we can use to progress the knowledge on these fields. Thank you to the organizers. It was a beautiful session.
Thank you so much. Thank you so much for sparing so much time. Dr. Udani, Dr. Tipu, you would like to add something?
I think already Margaret has explained in each and every bit of details so elaborately. I think there's nothing left to further discuss about this, as she said, very important topic. And since it's relatively new in the field of neurology, so I think in the coming years, we expect some more new insights into this exciting and yet treatable clinical condition. Thank you once again, all the youngsters who presented their cases, experts for their valuable experiences, and last but not the least, Shifali for organizing this excellent clinical session lasted for more than 2 hours at this stage. Thank you once again.
Thank you. Dr. Udani.
No, thank you very much. I echo both the speakers, whatever they've said. I think it was a very nice session, and Professor Nasadini has done a great job by clearing many doubts and problems we have. Thank you very much.
Thank you. Thank you so much. Thank you very much. Professor Margareta, I forgot to ask you at the beginning of the session. We record all these sessions and we're putting them on YouTube of the AOC in India channel. Is it permitted to put this session as well? Thank you. Thank you so much. Mahesh, closing remarks. The secretary has to speak up the closing remarks.
It was a very nice session with very good case presentations. And we'll be meeting again next Wednesday with another interesting webinar and some interesting case discussions. Details will be put
Really
in the
grateful,
website.
Professor Nasidini, for staying so long. Thank you very much.
Thank you.
Thank you. Bye. The certificates will be mailed to the presenters. Yeah. Yeah. Thank you.